Here we go. Right. Okay. Okay, cool. Now we're back on track. Oh, okay. Anybody have any questions while we're getting signed in on this? About lecture, about lab, anything?
For the lab, we're going to be also recording the responses from augers.
Yes. So today we'll be getting our results from the selective and differential media. And that is going to include, and I tried to write a note on the board so that we wouldn't forget because it's been a lot lately, but remember that when we look at our nutrient auger, our TSA, same things, that we get our, at least a picture so we can record our colony morphology, because we didn't get to do that previously, knowing which one was our gram positive and gram negative. So at least get a picture. When we submit those forms for our unknowns, in that section where it has colony morphology for our gram positive and gram negative, and I'll remember when we get closer to submitting them, because I know that, you know, there's going to be questions about that when we get to that, but I'm only particular put like 3 descriptors. I know there's like all these categories and all these words that we could choose from for describing colony morphology, like that it was round and that it was, you know, opaque versus transparent, or what color it was or whatever. As long as we have 3 descriptors, I'm good. So that's all I'm looking for. Just 3 terms for each gram positive and gram negative. So I don't need it. I'm not that concerned about colony morphology, if I'm being completely honest. And our blood auger, I don't want to say it didn't behave, but because it was some older auger that I had used from the last semester, and sometimes when they sit in the fridge for a while, they get thinner, like they just dehydrate. And because of that, our ones that did hemolyze and break down the red blood cells, like hemolyze the whole plate, as opposed to just like the halo like we're expecting. So luckily, that's not something we need for determining our identification. But what I'll tell you guys is that on the exam, when I ask questions about hemolysis for the blood auger, I'm not going to give you like a plate that you have to look at and do the assessment on. I'll just ask a question about, you know, what kind of hemolysis would have a clearing of a halo, and then you would have to know it was beta, for example. Okay, so it'll be like concept stuff because we didn't get to actually see proper behavior in real life. So I'll let you know that I'm not going to be depending on recognition for that one anyways. All right, so I'm gonna go ahead and start this. Remember, you guys can always join in. This one's pretty forgiving for that. And then we'll play through that. I'll just get the other things ready. Chapter 17 is going to be a lot of kind of review or expect, knowledge from past chapter 16. Let's see. Excellent. All righty. Okay. Good job, guys. Sorry that it's silent anymore, but it's that or echoey weirdness. And I think, yeah, better this than echoey weirdness. Okay, so let's put this back up. Okay. Cool. Okay. So chapter 17, like I said, this is going to involve a lot of knowledge and understanding of chapter 16 in order for us to really like get the most that we can out of this. So I hope that we have at least got a little bit of understanding of you know, how antibodies work, what the different antibody types are, because we're going to talk about that in some of these disorders today. And don't worry, I mean, I'm going to review a little bit about it. And also T cells and what they are, and basically what they do. To start with, immunopathology, this is a term that we need to be aware of as far as, you know, what this whole chapter is even about. So we're talking about diseases associated with the dysfunction of your immune system. That could be overreactive or underreactive. Our overreactive ones just means that we're talking about reacting either to things that you shouldn't be reacting to, or you're literally just having an overreactive response to something. For example, good examples that we're going to be talking about today: allergy. Why are you reacting to cat dander? Why are you reacting to peanuts or whatever it is? And then like things like autoimmunity. Why are you reacting to self? Because that's essentially what autoimmunity is, having an immune reaction to self. And we've already talked about you're supposed to have eliminated that during your maturation process. And then we're going to talk about hyposensitivity. So hypo being low. Hyposensitivities, we're mostly referring to immunodeficiencies. So those can be exchangeable terms, hyposensitivity versus immunodeficiency. So we are lacking in some aspect of our immune system and can't fight off diseases the way that your immune system is designed to. So that's what we'll be getting into. This is a good little summary table over what we'll be talking about in the top. We have our primary and secondary immunodeficiencies that we'll get into. That's going to be the last part of the chapter. The first part of the chapter is mostly going to be focusing on our hypersensitivities. So there's 4 types: type 1, 2, 3, and 4. We'll get into them in order, but type 1 is mostly your allergies. Type 2 is going to be associated with IgM and IgG reactions, mostly to blood types. That's going to be our concern. So we're attacking cells with our antibodies, so mostly complement related. Okay, so it's classical pathway of complement activation. And then type 3, we have also our antibodies again. So it's going to be IgM and IgG, but it's when they bind to antigens that are floating around in your body. And when you have antibody and antigens, we talked about agglutination being a function of our antibodies. Well, they can, like, those agglutinated antibody antigen holding on to all these fidget spinners all around us and whatever, and creating these clumps, can get stuck in tight spaces in your body, like your capillaries and your joints and stuff. If that doesn't sound like we're going to go in the direction of some autoimmune diseases like lupus and rheumatoid arthritis, that's exactly where we're going to be going with the type 3 stuff. There's other ones as well that we'll get talking about too, including the APSG, which I'll say the words when I get there. If I say it too many times, I'm definitely not going to be able to say them. It's like I get like a certain number of tries on some of these words, words that I don't say very often that you guys would probably laugh at me for, but you guys get to see your say your pathogen names later on in your presentation. So I'll get to, in the inside of me, of course, I'll be very encouraging up front, but maybe on the inside, I might laugh at you at how you pronounce them. But anyways, type 4 is going to be our delayed type reactions. This is going to be your T cell related. We'll talk about how come that's delayed as well. So we'll start off with our hypersensitivities. Our hypersensitivities, of course, are overreactions. This is going to be exogenous versus endogenous triggers. Our exogenous, anything that's coming from the outside, that's going to be pollen, cat dander, peanuts, anything being introduced into the body that you're reacting to. Endogenous reactions, that's going to be mostly our autoimmunities reacting to self. So you can have those reactions. Again, we already kind of outlined what our types are, but type 1 being allergies, that's really associated with IgE. And IgE is that antibody that was developed by your body to react to parasitic infections. So parasitic being protozoa and helminth infections. But here, obviously in the United States and other developed countries where we have proper hygiene principles in places, cook your food all the way through, wash your hands after, using the bathroom, and using PPE in hospital settings and things like that, we've almost eliminated completely parasitic infections. And so our immune system still has that in its arsenal. And if we don't train it how to be used properly, it doesn't know how to react. And that's where we get allergies, or at least that's the theory behind it. So that's IgE. Type 2 is IgG and IgM, and we're going to be causing cell damage, particularly to red blood cells, when we're attacking them due to antigens that are on the surface. We'll talk about blood types. And then we already talked about type 3 being immune complexes between antibody and antigen, and type 4 being cell mediated. This is a good little summary chart that gives you more information and examples relating to those things when you guys come back for studying. All right, so type 1 are allergies. These are hypersensitivities that are basically defined by the amount of inflammation that is being triggered from our response. So this is going to be immediate onset, typically whenever you are coming into contact with these guys. And before I forget, it's going to be immediate onset. Usually, for example, I'm allergic to cats, right? If I go over to somebody's house and they have cats, even if they've cleaned their house and whatever, I'm almost always going to have itchy eyes and an itchy throat and like a rash develop on my skin, typically my face first, but within like 30 minutes to an hour, and that sort of stuff. So this is pretty immediate onset, and it starts right away. It's just you might not see or experience the symptoms, noticeably for an hour or two. But here, what we mean by immediate, it's not a couple of days later. It's definitely within the realm of a couple of hours. So this is always associated with very specific antigens. In fact, I can tell you, I can attest to this because I might be allergic to cats, right? But when I was in graduate school and I spent a lot of time at my friend's place, they each had cats. So it was like 3 people living there, and 2 of them had cats. So 2 different cats. And I spent so much time there that eventually I was not allergic to those cats anymore. I could just be around them, no problem whatsoever. Just got used to, my immune system was used to seeing those cats, but I'm still allergic to like everybody else's cats. So it can be very specific to like, a specific thing. So this is antigen, epitope related stuff. This is not, innate response stuff. All right, so there's 2 levels of severity associated here. We're talking about atopic versus anaphylaxis. And the difference is going to be that atopic is talking about local reactions, as opposed to anaphylaxis talking about systemic reactions. Of course, that's going to be a bigger deal because atopic, local, here we're talking about itchy eyes, itchy skin, something like that, but it's not all over your body. If you're allergic to something you inhale, if you have asthma, we're talking about a local respiratory response. But if you have anaphylaxis, we're talking about in your bloodstream, we're sending all of these regulators for an inflammatory response throughout your entire bloodstream. That response where we're talking about, thinking back to chapter 15, in your inflammatory response, where you have your vasodilators and your vasoconstrictors and things like that, and increasing blood flow to areas and all that. Imagine that happening over your entire body and controlling, how much your bronchoconstriction, how much air is getting into your lungs and stuff like this is being regulated systemically. Well, anaphylaxis can become an issue, become a deadly issue very quickly. Most of us have heard of anaphylactic shock and might not have considered it to be an allergic reaction, but it is truly an allergic reaction. Anytime that you have anaphylaxis going on, it's almost always going to be allergically related, but there's different triggers that we have. So most of the United States is going to have some kind of allergy, but about 50% have what we would call airborne allergies, so our respiratory contact allergies. There is a genetic component to our allergies, but like we've said, with a lot of your antibody, like rearrangement of your genes and everything like that, there's a lot of variability from like parent to child. So it even brings up the fact that, you know, prospect of your child developing an atopic allergy, so like cat allergy, is 25% if one parent exhibits the symptoms, 50% even if we also have the grandparents or siblings being affected. So my dad is allergic to cats and my mom is allergic to cats and I am allergic to cats. My sister is not allergic to cats. So it's not necessarily this whole thing of, well, both parents were allergic. And so therefore the kids have to be. My sister has a cat and is fine with that. And has always been fine, but not me. But yeah, so that's the idea, because we have that genetic rearrangement going on in your antibodies, and this is antibody dependent. That's why this can be variable, genetically speaking. Also, the other side of this is, and what we're going to talk about in a minute, I think yes, it's the next slide, is the hygiene hypothesis, which is that in developed countries, we have eliminated sort of this exposure early on to things like parasites and all this to train our immune system how to appropriately react to things. So if you haven't seen parasites early on in your existence, and that hasn't been part of, you know, your exposure, your IgE response and things related to that parasitic response hasn't been trained appropriately on how to react to environmental things. It hasn't been told what's self, what's foreign, and then that stuff in between. When I say stuff in between, think of all the bacteria that are in your gut right now that are bacteria. They've got peptidoglycan, they've got LPS. Most of your gut bacteria are gram negatives. They've got endotoxin, you know? So that should be seen as foreign, but in that gut environment, that is seen as not a threat, essentially. It's not seen necessarily as self, but it's not a threat in that area of your body. So how do you train your body how to deal with IgE or eosinophils that are part of the response to all of this? Well, you can't if you don't get exposed to it. And so that's why they think allergies have come to exist, is hygiene. We've just eliminated that training aspect of our past. So our immune systems need to be trained by interaction with our microbes as we develop. And that usually happens at very early ages. We're talking like from baby up to like maybe like 4 or 5 years old. And then past that, you've almost missed your opportunity to train your immune system on what is a threat. So the industrialized world, or what we call the developed world, has, you know, come to have allergies because of this. And this is something to consider specifically because here in the developed world, when we call, what we call developed, right? However you want to look at it, but we think, you know, keeping clean and keeping disease at bay is a good thing and something that we need to have. And of course it is. It's extended our lifespan considerably, but we've also lost something in that process. Is that surprising? Of course not, because we don't always, as people, know what we're doing. You know, we don't always know the consequences of our actions long term. Of course we don't, because look at global warming. Look at the effect that we've had on our climate. Look at the plastics that are in our oceans and things like that. We thought we were doing good, but turns out we're just making a mess of things. It's just is, you know, proof is in the pudding, right? So how do we move forward from something like this? People have suggested that perhaps, you know, introducing some sort of parasitic element, not necessarily directly like causing infection with parasites, which has been proven that if you do that, you can ease allergies. So it has been directly related, but you don't just give people worms. That's ridiculous. So how can we introduce maybe parts of that and like induce that response earlier on? So that's stuff that's being looked into by immunologists that are more interested in the allergy side of things. I don't really know much about it outside of that, but somebody had asked something I thought I would bring up. Somebody had asked in my class yesterday, my lecture, had brought up somebody who is very fair-skinned and has family members who are darker skinned, and that they are having issues with eczema and the lighter skinned people are not. And how is this genetic? Like we're talking about like this mother is very light skinned, very fair skinned, and her family members having the darker skin, and her children that have the darker skin also are having the eczema, whereas the children with the lighter skin aren't. And how is that related? And I hate to break it to you, but these things actually do play a part in our immunology as well. Probably a whole lot of other things too, right? This is not just immune related, but she's happened to notice this. So if you think about it this way, when we talk about the tropics, because I thought this was a really interesting conversation, is why I'm bringing it up, but think about the tropics and where we have darker skinned populations originating from, as far as like the evolution of mankind is what I'm talking about, okay? Not current things, but where we have parasitic infections the most are going to be in our tropics. That's going to be in sub-Saharan Africa, in Central America, in India, in the tropics, right? And it makes sense. And that's where we have darker skinned populations because they have, evolved to have melanin that is protective from sun, damage. So not surprisingly, in those high, temperature areas, we have parasites and the higher risk of sun damage. In places like Scandinavia, where you don't have these issues with the sun, where we have lighter skinned populations that grew to be, more populous in those areas, that they don't have as many parasitic diseases either. So they were less likely to have a stronger parasitic response than folks who lived in those areas that have like the higher temperatures and the higher parasites. So if you are coming from a population that has higher incident of parasitic infections, your immune system is going to be more highly adapted to dealing with that. So you have a stronger parasite response. That's great if you are living in those areas, but now you come to developed countries and you're not having that stimulus, you are potentially more likely to have certain types of allergic responses as well. So I thought that was a really interesting conversation, that people don't necessarily link these seemingly unrelated things to one another, but they might be. But that hygiene hypothesis sort of drives that concept home. So I didn't want to leave that out because we don't always think about the bigger picture of these things. All right, so allergens, we can classify them. This is easy stuff. Classifying them based on their portal of entry. This is going to be inhalants, ingestants, injectants, and contactants. And you need to know like those four. Again, you guys get multiple choice, so that's not too difficult. If I were to ask you about which category, let's say pollen fell into, of course, that's going to fall into the inhalant. You get, rhinitis, you get allergic rhinitis, you get the runny nose and the itchy eyes and everything from inhaling these things. I feel like these things are pretty straightforward. So this is a good little chart to refer back to if you're trying to determine what might fall into what category. And of course, there's crossover. Of course there is. So we've got things like our drugs for our injectants, and our drugs for our contactants, and our drugs for our ingestants. So if you take a drug orally and having a reaction versus getting it injected into your bloodstream and having a reaction, and then versus putting a drug on your skin as like a cream or something and having a reaction. Of course, they can cross over into different things. It just depends on how you're being exposed to them. All right, so here is how your cellular response works as far as responding to an allergen. All of this depends on a sensitizing dose. So that sensitizing dose is just like when we were talking originally about our primary response versus our secondary or amnesiatic response with our antibody. So when you first see something, you have to trigger that response, clone out the right, T cell captain, and then you have to have it, interacting with the right B cell and activating it, and then it clones out and makes plasma cells that crank out antibody. And then we are going to shift from IgM to one of the classes, depending on what signals we get. That could be IgG and or IgE, for example, depending on what signals you're getting, right? So the idea is that you see this thing very, very first. Let's say it's pollen. It gets into your system, and your B cells are triggered to make antibody and get signals to make specifically IgE for whatever reason that we don't need to worry about, okay? They get signals to make IgE antibody because they think for some reason this is a parasitic infection, and they haven't been taught otherwise. So we're making IgE antibody, And what happens with IgE is sort of unique compared to what we think about with IgG floating around doing all these little things that it can do. With IgE, what it does is that Fc or constant region, the handle part of the antibody, it binds onto the surface of mast cells. Those mast cells, which are granulocytes, right? We had all the fills and then the mast cells. And so the fills have their function, but the mast cells are also granulocytes that are going to have the ability to hold on to IgE by their little handles and use them as receptors. So when IgE comes around, mast cells will be like collecting IgEs all from wherever and just hold on to them like that. For decades, they can hold on to them like that. And just be in your skin, in your airways, wherever they are, just holding on to IgE that sees pollen or pet dander or whatever it is. So they're always at the ready. So that's what happens in your sensitizing dose, okay? You make your IgE, you basically make IgM first, but then you shift to IgE. That IgE sticks onto the surface of mast cells and it just waits. So it's when you see your second response, to your amnesiatic one, that you're going to have that fast, immediate response. We had a latent period the first time you saw it, just like we do with every single antibody response. We had our latent period. And that's important. You might not think about it if you're allergic to pollen. You might not think about it if you're allergic to the cat dander or, dust mites or whatever it is. But if you have a bee sting, if you're stung by a bee, the very, very first time in your entire life, because it doesn't happen often, right? You don't get stung by bees all the time, I'm assuming. So you get stung by a bee your very, very first time. That first time is your sensitizing dose. You might not have any reaction whatsoever. You just get stung by a bee and it hurts and it welts up like a normal person would have. But you think, oh, I'm safe. I don't have any allergy to bee stings. I guess I'm good on that. Incorrect. That was your sensitizing dose. The second time you get stung by a bee, you might have an anaphylactic shock reaction and die. If you've ever seen My Girl, then you know what I'm talking about, right? So yes, if you haven't, it's actually a really good movie. It's one of those older now. I hate saying that it's older, but it's older now, comparatively speaking. It's worth seeing. It's a really good movie. Yeah. So it's cute. But anyways, so you have your sensitizing reaction. You might not even known you had the sensitizing reaction. The second time that you see the thing, though, now we have our allergic response. And so what happens is those mast cells are going to, with their IgE on their surface, grab onto pollen or pet dander or bee venom, whatever it is, and degranulate. And that means releasing whatever chemicals they have in their cells, causing their signals for inflammation. And that's what they do. They don't really phagocytose things or whatever. They mostly send signals for the inflammatory response to happen. One of the major contributors that they're going to release when they degranulate, when they release their contents, is histamine. That's one of the signals that they'll send. And I know that sounds familiar to you guys. So now we're talking about the histamine response. And of course, that coincides with allergies. So we have those IgE primed mast cells that can be there for decades, just ready to degranulate their histamines and everything else whenever they see whatever it is that the trigger is. So we have a couple obvious ones that we'll bring up. Hay fever. Hay fever is another term, colloquial term for allergic rhinitis. So we have different forms of rhinitis, and anytime that you guys see itis at the end of something, that means inflammation, always. When we talk about something being something, we say that that's both. Itis, it's going to be inflammation, right? We're talking about here rhinitis. So rhinos, we think of the horns on their noses. That's because that's your nose. So you think of rhinoplasties being nose job, right? So rhino, your nose, itis, inflammation. So inflammation in your nose cavities and your sinuses. So that would be sinusitis if we were talking specifically about your sinuses, of course. But allergic rhinitis is allergy-mediated inflammation in your nose. That's what this means. Can you have rhinitis without allergies? Of course. Now we're talking about acute rhinitis like we see with a cold. Of course, you can have that. Okay, but I just want to be sure that you guys are aware of the difference here with allergic rhinitis having inflammation because of allergies. So hay fever is the word for that. We can have allergies for pollen and mold that are associated with seasonal changes. For example, or like wet seasons and all that. We also have asthma, which is in fact an atopic response. So it's a local response within your respiratory system. So we have bronchoconstriction happening, but we aren't having a reaction all over your entire body. Typically with asthma, it's just in your respiratory system. That's usually from inhalants, but you can have that from foods and ingestants as well. With eczema, this is atopic. Again, that's going to be localized. Dermatitis. So this is derma being skin, itis being inflammation. We have inflammation on the skin due to an allergic reaction. Now, with eczema, it's not usually triggered by a contactant like you might want to think. It's not usually triggered by contactants or things on the skin. It's actually triggered by usually ingestants. So something that you're eating can trigger that skin response. And it can be other things as well, inhalants like it says, but you'll have that being expressed from your mast cells reacting in your skin areas. So that's eczema. That can be all over the body, but it is still atopic because it's on the skin. It's not affecting other systems in your body. We also have food allergies. This is usually ingestants, right? So this is getting in through the intestine itself and then having an inflammatory response being triggered from ingesting whatever it is. You might have things that are associated with food allergy that aren't necessarily associated with GI symptoms, right? We know you can eat shellfish and have like your face swell up and get hives everywhere and have bronchoconstriction and all this. You can have anaphylactic shock from eating shellfish. You can have anaphylactic shock from just smelling shellfish. And so depending on how serious your reaction might be to whatever that stimulant is. And everybody's different in how they can react to these things. But you can also have GI symptoms like abdominal pain and things. I found out that I was allergic to whey protein of all the things. Like that's a super common protein in like milk and stuff. I'm allergic to that, I guess. I was getting like ulcers in my intestines and found out that like if I cut out whey, I don't have any of my GI symptoms, but I never had eczema or hives or anything. I only ever had GI symptoms. So I just kept having pain in my stomach, and come to find out it's from that. I still eat cheese and stuff. Okay, guys, I just like try not to eat too much of it. And also when the pain comes, I know whose fault that is. But you're not going to take the cheese away. That's just not happening. It's just not. So you can also have drug allergies that can cause atopic reactions or anaphylactic reactions. We already mentioned that, but most commonly you're going to see this with penicillins and sulfas. It's also, people don't talk about it a lot, but you can have allergies to aspirin. And this is called a salicylate allergy. So you're not just allergic to aspirin. If you have this allergy, you'll also be allergic to any salicylates. And this includes, of course, aspirin, which is acetyl salicylic acid, but you'll also be allergic to salicylic acid, which if you guys use any skincare products, you've probably heard of that being pretty common exfoliant used for acne treatments, or even for bismuth salicylate, which if you guys don't know what that is, that's going to be Pepto-Bismol. So you would be allergic to that as well. So you couldn't, I don't know, that would be hard for me. I use a lot of Pepto-Bismol, especially I guess if I tell you that I have GI issues, that can't be that surprising. But you can be allergic to opiates and contrast dyes. It says in x-rays, but we all know that's going to be more CTE type stuff, which is pretty similar, but still. Right, so systemic anaphylaxis, getting into these guys, these are going to be characterized by, again, circulatory response with that inflammatory reaction, right? So all over the body because of widespread action in the circulatory system. Most of the time, again, we already said that with ingestants like shellfish, you might have an anaphylactic response, but most of them are going to be associated with injectants. And injectants are going to be mostly drugs and other things you would be injecting into the body, like serum from maybe other people for like things like Humira, where you're reacting to the antibodies and whatever. But bee stings and wasp stings and things like that are going to be our natural sources of that sort of stuff. So that's where you are going to see anaphylactic shock from those natural exposures as well. So that can last for decades after exposure. If we're trying to test for certain kinds of allergies, we can poke you in the back with small amounts of these and then see if you have any welts develop, basically. And we can measure the size of those welts to determine just how strongly you're reacting to something and then determine what your worst allergies are. Great if that tells you what it is and protects you so that you know to avoid those things or to carry an EpiPen or something. But we can actually use that information later on to desensitize, which we'll talk about. So how do you control your allergies? You're going to need anti-allergy medication. And this can be a wide variety of things. These could be anti-inflammatory drugs that just suppress that whole response that goes on with that IgE mast cell reaction. So this could be things like steroids that have an inhibitory effect on IgE production. The problem with drugs like that is that you need your immune response for a reason, right? It's not just going to suppress only that allergy reaction. It's going to suppress all antibody reaction or, maintaining the integrity of your organ systems as well. So steroids, if you guys know anybody that take steroids regularly, and I don't mean anabolic, I'm talking about like prednisone and things like that to reduce inflammation. If you know people that use prednisone regularly or get steroid shots, somebody was telling me about, one of my students in the last class was telling me about these Jesus shots or whatever that people get that have like anti-inflammatories in them. Steroids are going to be in there, as well as some other things like, B12 and whatever. It's supposed to make you like feel really great and all of this. Well, she had a friend that had Crohn's disease. So she would go get these shots and it would help her feel better for a couple of days. But then it's like she always got sick after, like a few days later on. That's because at first you're reducing your inflammation, but long term, if you keep relying on something like this, it's suppressing your immune response. And there's a whole reason that you're getting sick because of this.
She used to get steroids forever. And so finally get off of the steroids, like so many, like the doctor was like, I literally cannot prescribe you anymore. But that was the only thing that made her allergies feel better.
Yeah.
And then she had some like lung disease. So now she started taking allergy shots. And now she takes once a month, and that's I couldn't do any smells, allergic to dog. She was literally allergic to life.
Yeah, it's one of those things where like it will, because the drug is controlling your immune system isn't doing its immune system things. And so it doesn't know how to handle things when you take away the drug. It's sort of like when you guys have Afrin, right? And they tell you like only use Afrin for like 3 days, and then you need to be stopping with the Afrin because your nose will be dependent on Afrin to keep the swelling down. So that if you don't have Afrin continuously, your body doesn't know how to keep the swelling down. So it's just like that. It's exactly the type of reaction that we're talking about here. Steroids, and I'm not just talking about things like prednisone, like obvious ones, but if you use hydrocortisone cream on like skin rashes or something like that, it's one thing if you're putting them on bug bites once in a while, but if you're using it long term on your skin, it doesn't just have a problem, like cause problems with your immune system, but it causes problems with your skin integrity. And it can actually like thin your skin to the point that it will make you more susceptible to infection, as well as to tearing of the skin, like just your skin can just tear. So people with eczema who don't want to go to the dermatologist or are sick of dealing with the dermatologist might go buy over-the-counter hydrocortisone cream and just put that on, but that leads to problems with the integrity of the skin. And we already learned how that's part of your first line of defense against infection and things like that. So that can be detrimental long-term, just from short-term, like I say short-term, but like you're using that for a year or two, but it can cause problems for the rest of your life just from that year or two of overusage. So that's the problem with anti-inflammatories like that. We also have antihistamines. Of course, this is great for stopping atopic allergies. It doesn't really work very well for anaphylaxis because they're typically not very fast acting. You have to take the pill and maybe 30 minutes to an hour later, you start feeling the Benadryl effects, right? But if you're having an anaphylactic shock, you need that response immediately. So it's not great for that, but for atopic allergies, or like if you know you're going to a friend's house that has cats, take some Benadryl, or if you're taking Zyrtec or something like that, that can control these responses as well. They're great. Some of these guys cross the blood-brain barrier. That's why we get drowsy whenever we take Benadryl. It crosses your blood-brain barrier and affects your brain as well as the rest of the body. But some of these are like less likely to cross, like when you have Zyrtec or Allegra or Claritin or something, they don't cross as easily, but they still have an effect on that inflammatory response, including histamine. Obviously, if you're having anaphylactic shock, the thing that you're going to reach for is your EpiPen. The active ingredient that's most important in the EpiPen is the epinephrine itself. Epinephrine is the same thing as adrenaline. Here, we're just talking about terms as far as medication term versus like physiological term, right? They're the same thing though. So they're interchangeable for the purposes, at least of this class, and probably for physiology as well. But if you get into medication, they're going to call it epinephrine. So epinephrine, it increases the ability of air, I guess, what do they call it? Right, reverses constriction of airways. That's what normal people would say. Reverses the constriction of your airways so that you can breathe easier again. And that's pretty much what that is all about. So in your adrenaline response, if you were like running away and panic and you're scared or whatever, your body is trying to get as much oxygen to your brain and your muscles as possible so you can get away from whatever this scary thing is. We know about your adrenaline response, but we can kick that into action with your allergies, with your anaphylactic shock as well, to preserve your life, because that's what your adrenaline response is there for naturally. We can force that with this epinephrine and introducing it that way. However, adrenaline and epinephrine are very short-lived. They might buy you 30 minutes, maybe an hour, depending on your metabolism and what's going on in your body at the time. So it's a short half-life. And so if you are having an anaphylactic response to a bee sting or to shellfish or whatever it may be, and you pull out that EpiPen, you flip that cap off, you pop it in and press the injector down, and that's one use. It's done after that. If you don't carry more than one EpiPen on you, you need to be heading to the hospital right away, because once that EpiPen wears off, you're not good to go forever. No, because you have only enacted that response for as long as it lasts. If you're still around the thing that's causing the allergic response, or the allergic response hasn't cleared from your body yet, you're just going to keep having that response again once that EpiPen wears off. So EpiPen only buys you time. It is not curative. So remember that. If you're ever with somebody that's having a reaction, they use their EpiPen and they're like, oh, okay, now we're in the clear. No, take them to the hospital. Make sure they're getting the treatment that they need so that they don't have another reaction and they don't have another EpiPen on them. You don't want to see that. Another way that you can treat your allergies are through desensitization. This is essentially like exposing you to small amounts of what you're allergic to elicit a different response. So you've already had your IgE response with these mast cells holding on to IgE like little flags and just waiting to be activated in histamine response, right? But what if we could get a different immune response to those allergens? Let's say if I am allergic to cats, you introduce a little bit of cat dander, like allergen, antigen, right, into my body slowly, accompanied by signals to my cells that tell them to make IgG instead. So we've already got the IgE reaction going. We can't get rid of it, right? That's unfortunate. It just can't go away. But if you introduce cat dander with signals saying, make IgG against cat dander instead, what's going to happen is IgG, we already know with our workhorse antibodies, IgG, right? That's the big daddy, the one that we want in our memory responses and everything like that. It does a lot more for us in our immune responses. It's made 80% of your antibody response is IgG typically, if you can make that response. So if we can trigger IgG to cat dander, it will bind up all of the cat dander before the mast cell IgE thing can even happen, because it's so fast and so effective. And so we stimulate IgG to cat dander so that you no longer have the IgE response to the cat dander. That's the goal. So block it out entirely. This doesn't work well for foods. It mostly works better for inhalants and contactants. Just because of that intestinal response, IgG doesn't have a lot of a role to play in the intestines. It has more to play with other parts of your body. But so, all right, so that's the goal with that, desensitization. So here are strategies for blocking your allergy attacks. First, we have blocking the events in allergy. We have our steroids in this first section, blocking IgE production. Second, we have basically blocking the production, the degranulation of our mast cells, or by blocking the IgE from even being associated with the mast cells, which we can do with our IgG. And other things. We can have infusions with monoclonal antibodies as well. Then we have blocking the histamine response with antihistamines so that you don't have that vasoconstriction, vasodilation, control that better and keep it more homeostatic, right? Avoiding the allergen, go figure, put it in the medical charts, make sure that person, my mom had a bad allergic reaction to iodine. I say it's bad. She didn't know. she had some sort of, she got hot all over her body one time when they gave her iodine for some sort of CT scan or something. And like, she went back in for a second scan, like a year or two later. And the doctors were like, "Are you know, have any reactions to the iodine?" She's like, "Well, last time I got a little hot, but that's all. So no, I don't really." And they're like, "Yeah, no, we're not, never again on that one." And she's like, "I didn't have that bad of a response though. I just got a little hot." I'm like, "Mom, that was the first time that you experienced this. The second time, you might just die flat out on the table, and they don't want to deal with that. So how about never again?" So there was that, but things like that, just making sure, I mean, are your patients always going to be good about telling you about their allergies? Probably not. So that's something to be aware of. They may not know about it. They may not understand about it, and they just might not be telling you because they might not think it's important. Exactly. They might not be able to tell you. If you have something serious like allergies to penicillin or something, you might consider wearing like one of those bracelets or whatever that says like severe allergies like that, so that if you do become put in a situation where they might give you a drug or you're unconscious and you're at a new place, that lets them know about that sort of a thing, including like if you have, diabetes and stuff like that. If you go unconscious, it's nice to know if you fell unconscious in the middle of the mall, EMSA might like to know that you had diabetes and that, they could just treat it accordingly. So just those things are pretty helpful. But anyways, desensitization, we already talked about introducing little amounts to trigger that IgG response. Next up is our type 2 responses. So that's where we're going to get into our blood type stuff. I'm having some sort of allergic reaction right now. So we have our ABO antigens on your blood cells. There are 4 blood types: A, B, AB, and O. So this is basically telling us that A and B are equally dominant. We'll talk about how this is going to work in a second. And then O is recessive. We remember this from our genetics, right? So when something is a dominant trait, it's going to be expressed preferred over recessive traits. However, when something is equally dominant and you have one gene from your mom that's an A and one gene from your dad that's a B, you will express both. So that's where that is coming from, okay? So you can have all sorts of combinations. So as far as your genetics go, you might have genetics, an A from mom and an A from dad, making you AA, or an A from mom and an O from dad, make you AO, and that's be your genotype. But your phenotype, what you're expressed, will be A, because A is dominant over O. So we see that easy enough. Then you look down here at AB, they're equally dominant, so you're going to have expression of both, right? So this is where that concept of O being recessive. So you can't express O as your blood type unless you have 2 O's. All right. And so this will make sense when we look at the structure of the blood cells and how these antigens are presented on your blood cells. I'm going to go past this slide. We'll come back to it in a second. Look down at the bottom at type O, where we've got those 2 little red circles, and then look at the ones above it, A, B, and AB. They all have the 2 red circles. So O is like your baseline. It's like what everything is built off from. So obviously with O, everybody sees that as self. Everybody sees that as friendly. That's not bad guy stuff. We can't react to it as bad guy stuff because we all have that as our baseline, right? That's in the base of your A blood type. It's in the base of your B, and it's in the base of ABs. The difference comes in when you look at AB, where we have on your red blood cells both A and B on there at the same time. And the O is underlying, of course, in the background. So this is how our blood cells would be structured as far as what's expressed on the surface, given whatever your genetic genotype is, what your phenotype is going to look like on the molecular level, okay? So those are the antigens on the surface. So we come back up to this chart here. This means if your genotype is that on the far left, this is literally like what genes you inherited from your parents. This is what your phenotype would be, what your blood type is. A, B, AB, or O, okay? And that is talking about whatever that antigen is on the surface of your red blood cell. So those things tie together. However, if you are A blood type, I am A positive. So I will have antibodies against B, because to me, that's foreign. I've never seen B before. Will I have antibodies against O? No, nobody does, because that's the base. It's like if you have red blood cell that's naked, that's O. Everybody has red blood cell. And then you have either A or B, or both A and B, or none. And that's the idea there. So A's have only A. So to them, B looks weird. It looks foreign. B's have only B. And so to them, A looks weird. That's foreign, right? So look at ABs. Does A look weird to an AB? Nope. It looks like self. Does B look weird to an AB? No, it looks like self. Does O look weird to an AB? No, it looks like self. Uh-oh, I think we've learned something about ABs, which is that they can receive any blood type. So lucky them. AB is the universal recipient. O, though, we look at O's. Does A look weird to O's? Yeah, it looks foreign to them. They've never seen it before. Does B look weird to O's? Yeah, it looks foreign to them. Uh-oh, yeah, oh shit, exactly. O's can only receive O. To them, A's and B's and AB's look foreign.
So they can help everybody, but only themselves can help.
Exactly. So AB's are going to be our universal recipients, because they can get anything. They don't see anything as foreign, must be nice. And O's are our universal donors, because they can give to anybody. Anybody can receive O. That looks like friendly to everybody. So of course, then we get into that whole, that's the ABO groups. Then we also have the plus or minus, the positive or negatives. We're going to talk about it in a little bit, but that's called rhesus factor, RH factor. And RH factor, you either have it or you don't. So obviously don't is baseline. And if you have it, that makes you have this extra antigen on there. So if I'm AB positive, I can receive A. So I'm not AB positive, just to be clear, but I'm A positive. But still, if I was AB positive, I can receive any blood type ever, even AB negative, right? If I'm AB negative, I can receive any negative. I can't receive any positives. So the positive automatically is out, because I've never seen it before. It's weird. So it's just an extra layer on top of this, the A or the B or the positive. Those are the things to worry about. But yes, so this focuses on the ABOs and what you can receive there. So our universal donor is the type O, and the recipient is the AB blood. My sister actually is AB positive. Lucky her. Yeah, so it's nice, right? So my sister's AB positive. My dad is B positive, and I am A positive. I don't know for sure what my mom is. She's got to be A something, right? She has to have an A in there. Otherwise, it doesn't work out. But she has an A in there somewhere. She just doesn't know. Yeah, sort of. I mean, O is, since it can be, it's like the naked cells, basically, right? So anybody can get that. And it's like the basics of everything. Now, I will say this: the most common blood type in the population is, but in the world, but we mostly focus on the United States. So that's going to be O positive, actually. Even though it's a recessive trait, you can carry it. If you're AO, you're carrying the O with you, so then it gets passed on to other populations underneath. There's also been correlation with O being less susceptible to malaria. So it's a more desirable trait to be carrying in the population. So that kind of makes sense long-term wise, what we're talking about, evolution wise. But O positive is the most common. O negative is less common. It's on like the not quite middle, but like less common than the middle. But it's not the most uncommon. But if you're O negative, you can only receive O negative. If you're O positive, you can receive O positive and O negative, but that's it. But man, if you're O negative, you're the universal donor, you can save anybody's life. But if there is a mass casualty situation that you're involved in, they're going to shove O negative at everybody. because they don't know what your blood type is at first. They'll get a sample and try to type you, but in the meantime, we're going to give you O negative. What happens if you have a patient that is O negative coming in with all of that? Well, they can only get the O negative. And what if you've used it up on everybody else in that mass casualty situation? And that's why typing is going to be so important up front in a situation like that. They have protocols at hospitals for mass transfusions, whether it is for an individual who has serious injuries that's going to need like a lot of bags of blood, or for mass casualty situations that they'll have to enact. Basically, it involves calling OBI to bring up extra blood at the same time as having, circumventional sorts of procedures to get around pushing more blood towards patients as well. So anyway, so the problem with all of this is that if I'm saying like I have anti-B antibodies in my blood, right? I'm A positive, so I have anti-B in me. What happens if you give me B? Right, I will die. That's very common for people to die from having the wrong blood type transfused to them. And what happens at the like immunological level, my anti-B antibodies go and bind on those B blood cells. Like if my dad gave me blood, right? My antibody for anti-B would bind to his blood cells and would initiate the complement cascade, that classical pathway of the complement cascade, poking holes in all of those red blood cells, leading to inflammation system-wide and all of that. That in your actual bloodstream will trigger a shock response very quickly, because your body is like, holy cow, why is there all these destroyed red blood cells everywhere? And it will essentially respond as though you're going through this serious reaction. And that leads to shock, which will lead to, extremely lower blood pressure. It can lead to jaundice. If you survive this, you will have jaundice and you'll have to go through dialysis to remove like the toxic products of having like, ruptured cells all throughout your bloodstream. And that just keeps signaling. It's like we said with complement, it's a cascade reaction. It's just going to amplify itself. So you can die very quickly. If you can catch it early enough, we want to essentially filter out all the hemoglobin that's being released into the bloodstream that's triggering that shock response. And that's the only way we could, help you survive. So moving on to the Rh factor, this is the positive or negative associated with your A or your B or your AB or your O. So you're either positive or you're negative. So there's not multiple options here. So if you're positive, you have the thing, and that's great. If you're positive, you can receive the positives or the negatives. But if you're negative, you don't have the thing. So the positive, the plus on there, looks foreign to you. So you're going to react to it. So that's a problem. So this brings us to hemolytic disease of the newborn. This is an extremely serious reaction. Do not underestimate the value of RhoGAM. And I'm being completely serious about this. Don't worry, we're going to talk about it. Yeah. Right. So RhoGAM is essentially a gamma globulin. It's an antibody that's going to block the antibodies that the mother would make to the fetus. Yeah, potentially, yes. The shots do themselves. Yes, the treatment itself does, but the antibodies should just be doing their job after that and protecting just fine. But the idea is, if you are Rh negative and you've never seen positive, you make antibodies to positive. It's just how it goes. So if you're Rh negative and you are having a child by somebody who is Rh positive, and now you're carrying an Rh positive child, it's the first time that your body has had Rh positive in its system, right? So you'll make antibodies against it, but it doesn't happen right away. As the fetus is developing, it doesn't necessarily have those markers right away. This will happen later on in the pregnancy. Plus, we have the barrier between the mother and the child with the whole placental barrier thing going on. So this usually isn't too much of an issue until later on, closer to birth. And so what'll happen is you make your antibodies, and we already know, first you have to have your sensitizing dose. You have to go through that latent phase of making antibody against something, and that takes time. If that's happening very late in pregnancy, your first baby, you would never even know you had a reaction or that you made antibody to it or whatever. So it's the second baby where this is the issue. So if you've had a baby that's Rh positive, you might be fine. Everything was good to go, no problems whatsoever. But your second baby, you're already sensitized. What are you going to crank out? What's your body going to crank out? IgG to your baby. And so to your baby's blood. specifically. So when we get later into that pregnancy and we can start reacting and seeing those as foreign, we're getting closer to birth. You've carried this healthy baby to term, and now you get to give birth to a stillborn child. And that's what happens with hemolytic disease of the newborn. Babies can be born alive to this. They will have serious defects associated with having had this response, and it can be very difficult to save them. But more commonly, you're going to have death associated with it, death of the fetus. This happens today. Don't think this is something from the old ages. This happens today. Yes. I would assume, but I don't know enough about it. So, so you can imagine this could potentially happen with ABOs as well. It's just not as much of an issue as it is with the Rh factor. We just see more of an issue with it. And that's why we have RhoGAM, which is dealing with specifically Rh factor, as opposed to A versus B stuff. But you can see this hemolytic disease happening from A versus B stuff. It's just not going to be as severe. Death results from this Rh stuff. Okay. So you are pregnant with your second child and you move across the nation because your husband's in the military or whatever. I don't know what people's stories would be, but let's say that's your situation and you get a different doctor and you didn't know that you had this Rh incompatibility going on, and your new doctor didn't think to test it because you didn't mention it, and medical records didn't get transferred in time before you're having your baby, and now your baby dies. This happens today. I usually have every semester at least one person know somebody that this happened to. They lost their child because of Rh incompatibility. This is, like, when I say this is still today an issue, it really is still today an issue. You live in rural Oklahoma where they're not doing as much testing. You're going to see this. So be aware, the value of RhoGAM just blocks that from happening. This is why if you go to a hospital, if you go to Integris now and you're Rh negative, they don't care that it's your second or first, whatever. They don't care. They're just going to give you RhoGAM. Because if you test Rh negative, they're like, not playing with that. Here's your RhoGAM shots whenever it gets to that point of the pregnancy, so that you can have a healthy baby and not have to suffer through dealing with stillbirth. It'd be one of the most horrific things that a mother could endure. So anyways, we're still pretty far along time-wise, so I'm not going to go over these questions with you guys again. But antibodies in type 1, that's going to be IgE. The difference between atopic and anaphylactic: atopic is local, anaphylactic is systemic. Best treatment for anaphylaxis is epinephrine. If you are O negative, you can only receive O negative. And B negative babies in an AB positive mother, is that a risk? No. So that's the opposite of what we're learning, right? So if you're Rh negative mother, you see the positive baby as foreign. If you're a negative baby, the AB positive, remember, if you're AB positive, you can see anything as friendly. Yes. So they would be fine. That would be a fine situation. All right. So immune complexes, this is type 3. This is when your antibody is seeing antigen in your body and they're binding it all together and making agglutination and doing their normal antibody thing. But they'll get stuck in certain parts of your body. The very, very tiny capillaries, the joints, tiny blood vessels in your heart, where we have oxygen exchange in your lungs. These areas can get clogged up with these immune complexes that can develop. When that happens, they get stuck in what we call the basement membrane of your endothelial cells, just getting stuck in your blood vessels, essentially. And then neutrophils and complement, well, geez, I keep grabbing this weird. Neutrophils and complement will take action and cause inflammation and signal for more inflammatory response. That can lead to damage of the tissue in those areas. So your blood vessels, your heart and lungs, your joints, your skin, where we have tiny little capillaries at the surface, and kidneys, where we have that exchange of toxins being, filtered out of the blood. So this usually depends on IgG, M, or A, and not as much IgE, right? This is not an allergic response. This is just your normal antibody response to something, and it doesn't matter what, and getting stuck in places in your body. It requires large doses of antigen because you have to build those complexes. Sometimes you can have reactions in hours, sometimes in days. It just depends on what's going on. in the body with that immune reaction. So our first example is acute post-streptococcal glomerulonephritis. That's the last time I'm going to say that word because I can't pronounce it more than once, okay? But this is in your kidneys. What happens is you get strep throat. Your body reacts to the strep throat, creates antibody strep throat complexes, and gets stuck in your kidneys. And then we have that inflammatory response in the kidneys causing inflammation, itis, right? Glomerulonephritis, nephro is your kidney. Glomerulo is the glomerulus structures inside of your kidneys that are dealing with, filtering and all of that. This is where we got those little tiny blood vessels being damaged. So that's what's happening, reacting to an antigen, gets stuck in the kidney during filtering process, inflammation. All right, moving on to type 4. But you can see how in this, if this is getting stuck in tiny blood vessels, like in the face, for example, you get the butterfly rash with lupus. If they're getting in tiny blood vessels in your joints or in the strictures of your joints, you're going to get inflammation there, leading to rheumatoid arthritis. So that leads to autoimmune diseases as well. Lupus so that's ankylosing spondylitis.
Oh.
Yes. So that's spinal and other skeletal issues that are going to, and what are they? Connective tissues. But yeah, anyways, type 4 hypersensitivities are involving your T cells. When you have memory T cells, those T cells have to be reproliferated back out. So those memory guys are going to hang out in few numbers. We see the thing again. It takes a couple days to remake them, not weeks like I did the first time. So it's still faster, but it does take a couple days. If you guys have ever had a PPD tuberculin skin test done, they will put the stuff in your skin and then say, come back, 48 hours later, and we'll measure it to see if it swells up. If your body has ever seen tuberculosis, it will have had a T cell, a cytotoxic T cell response to it, because tuberculosis is a bacteria, but it lives in your cells. So inside MHC1, right? That's going to be your CD8 positive T cell response. So that's what they're looking for when they do the PPD skin tests. So they want to know if you had a T cell response, and it's delayed by that, 24 to about 72 hours, just depends, but they say 2 days approximately. So that's our classic example, that tuberculin skin reaction, looking for a T cell response that might already exist to tuberculosis. They keep it in your skin so that they don't trigger a response with that tuberculin, because they don't want you to respond to the skin test and create memory against that, right? That would be counterproductive. But yeah, we also have contact dermatitis. This is different than our atopic dermatitis. Contact dermatitis is dealing with a delayed type reaction. So this is poison ivy and poison oak and things like this. You can also have these reactions to haptens that are like jewelry, metals, things like that. Latex can also behave this way. Like it says elasticized undergarments. I had a really bad reaction to like a Spanx that I had one time. That was really bad. What a weird thing to have, like your underwear causing a reaction, but it did. So, and there's certain drugs as well. But you can see the difference. If you have poison ivy, you have to have a sensitizing dose, again, to get your T cells involved. And then when you see poison ivy later on in your life, it'll be a day or two before you have your poison ivy rash show up. So you might touch that poison ivy and be like, oh God, I touched a poison ivy. A couple days later now, you have the rash. So that's not going to be an immediate response like we do with our allergies typically. But the hives that you get from allergies versus this oozy damaged skin reaction that you get from contact dermatitis is because your cytotoxic T cells and your macrophages are going out and destroying the tissue like they would in a normal CD8 T cell response. It's also the basis for graft rejection. Remember how we talked about everybody has MHC1, so they can flag down, hey, I'm infected, come tell me I have the alien bursting out of my chest or whatever. So any cell can do that, including your kidney cells that can be put into me that I have my lymphocytes seeing as foreign, because it still looks like MHC1, but there's something wrong with it. It looks like it's raising a flag, even when it's not. So that's the premise of graft rejection. My CD8 T cells will kill your kidney because of that. There's two different ways that you can reject grafts that are from transplants: host versus graft, which is the host killing the graft. That's the normal way. That's what we just talked about. Okay. But if I get bone marrow from one of you guys, that would be me getting your lymphocytes put into my body. You know, they're immature, they're in the bone marrow, but still, they're going to evolve with your MHCs on them, and they're going to see all of my stuff as foreign and attack my stuff. So that's your graft attacking the host. And that's going to happen only with our bone marrow transplants. All right, the classes of grafts that we have autografts that are from yourself. You get a burn on your arm and we need to do a graft for it. Then we'll get maybe skin from your back or something. We have isografts. These are grafts from twins. We could still potentially have a little bit of issue. We're talking about identical twins here. We could still potentially have issues just from differences in changes in lifestyles and exposures and things like that, but it's as identical as you can get aside from self. Then we have allografts that are anything from anybody else that's not an identical twin or self. And then we have xenografts that are grafts from animals. So it'd be like heart valves from pigs and things like that. Transplants can come from live donors. Like you can donate your kidney while you're alive. You can donate your bone marrow while you're alive. Most of the time, our organs are going to be coming from brain dead donors that are kept on life support. So that's your hearts and your lungs, and most of the kidneys are going to come from brain dead donors, not from living donors. But you can, if you're dead, like not on life support, but actually like died, then you can still donate like your cornea and other parts of the body that aren't as affected by the death process. And there are fetal tissues that can be involved in that as well. So autoimmunity, here we have hypersensitivity to self. This could be antibodies or T cell involved. And here is a list of diseases. I would be aware that these are autoimmune diseases, be able to recognize that they are if I give you like a question on a test. Is, type 1 diabetes an autoimmune disease? Yes, you should know this. So lupus, rheumatoid arthritis, ankylosing spondylitis, Graves' disease, which is autoimmune thyroid disorder, myasthenia gravis, which is muscle, type 1 diabetes, and then multiple sclerosis, where it's the myelin sheath, the covering of your neurons, that'll be attacked by that. And then the types of hypersensitivities involved, they're not all like immune complexes, right? Lupus and rheumatoid arthritis have immune complexes, but the other ones can have other types of reactions involved in their autoimmunity. This usually arises from molecular mimicry or infection. Molecular mimicry means that the pathogens look like you. So when we trigger a response to the pathogen, you're also triggering response to you. And that gray area in that overlap of what looks like you versus pathogen didn't get weeded out in that clonal deletion process that we talked about. Infection, here we're talking about just having infection with certain things can predispose you to having these autoimmune diseases. That means if you get infected with this virus, it can change the markers, what the markers on your cells can look like, either from genetic manipulation or by producing other things on the surface of their cells, like their spikes or whatever, while they're trying to bud out. We think type 1 diabetes and MS are related to some sort of viral infections, particularly maybe measles, but we're not 100% sure. Also, your gut biome is incredibly important in keeping your immune system in check. So if you have a fast change in your gut biome, that can lead to a change in your immune response to things as well. And that training process that's involved in making sure you know what is a threat and what isn't a threat. All right, onto the immunodeficiencies. This is primary versus secondary. Again, primary is anything present at birth, starting from square one. Secondary, you get it after birth. So this is an outline of primary immunodeficiencies. You don't necessarily need to know all of these, but it does outline several different versions if you're interested in immunodeficiencies. But we're going to talk about specific approaches. So ones that are affecting the B cells are going to affect your ability to make antibody, essentially. So anything that depends on an antibody reaction, like a lot of bacterial infections, could be affected. T cell issues are going to be more devastating because your captains, your T helper cells, are what's going to be dependent on for B cells and T cells. So your entire adaptive immunity depend on your T helper cells. So anything that affects your T cells is going to be affecting pretty much all of your adaptive immunity, including DeGeorge syndrome, where we have issues with T cell development in the thymus that can potentially be fatal, lead to fatal infections because we can't stave them off. So these children who have DeGeorge syndrome often have issues with infections that we wouldn't have to deal with as healthier individuals. Of course, then we have SCID, which is severe combined immunodeficiencies. There are different levels of this, but the biggest, most serious form of it is going to be X-linked, and that's the boy in the bubble disease. But these are going to be issues with B and T cell function. So different levels, like I said, some of them can be treated with, immune therapies and things like that. And some of them are eventually just going to be lethal if we can't keep these people in completely sterile environments. So usually you're going to have symptoms within days after birth, once you get off of that mother's provided, protective immunity. So on to the secondary ones. So those were our primary that you get from birth. The secondary are the ones that you're going to acquire somehow, usually through infectious or through metabolic diseases, or because of chemotherapy or radiation, obliterating your immune system. Your immune cells are pretty sensitive to drugs and radiation, so they can be destroyed very easily with those things, trying to target cancer, but you're also killing off your immune system. All right, so first one is AIDS. This is obvious one. It's acquired immunodeficiency. So you're getting this from HIV infection. HIV infects your T helper cells and other immune cells and destroys your immune function, just like you would see if you had this inherited in your T cell response, right? Except you're acquiring it later on in life. But yeah, that's the idea of that. So now you get all these opportunistic infections and the cancers, like we had talked about with Kaposi's sarcoma and Burkitt's lymphoma, things like that. Cancer itself can lead to immunodeficiencies. If you get cancer later on in life, and it is like, let's say, lymphoma or leukemia, that can affect your lymphocyte function as well. All right, and that was our last slide. Here are our last questions. Again, if you guys are of the predisposition to want to answer these, you can welcome to take a picture of it or whatever, but we're just going to go to lab now. And if you guys have any questions. All right. Bringing it all together, right? The next chapter, chapter 18, is pretty straightforward. A lot of the stuff is going to be old hat. We're just putting it in context of diagnosis. So it should be pretty easy. Chapter 18.